All right, we will continue on with our next speaker, Dr. Fran Cook-Bolden. I'm so happy that she's here with us today. She is a renowned board-certified Manhattan dermatologist / cosmetic surgeon for over 25 years, clinical assistant professor in the Department of Dermatology at Weill Cornell in New York, and also a clinical investigator for 50+ research studies in dermatology, laser, and the treatment of various skin disorders. She treats patients throughout the country and internationally at her New York office locations, and delivering a full spectrum of care, including cutting-edge cosmetic and anti-aging, as well as medical dermatology for all ages and dermatologic surgery. She is a native of Birmingham, Alabama, received her medical degree at Howard University, and did a full internal medicine residency at SUNY Health Science Center at Brooklyn, and then dermatology residency at New York Medical College. She is the founding associate director of the Skin of Color Center at St. Luke's Roosevelt Hospital Center. And she directs her own Fran Cook-Bolden Dermatology and Wellness, Cosmetic and Laser Surgery, and its associated group, Ethnic Skin Specialty Group. She's widely published, and not only in medical journals, but also in lay publications, and the co-author of Beautiful Skin of Color, a comprehensive guide to Asian, olive, and dark skin. And let me tell you, she's a media celebrity. She is seen in multiple TV morning shows, in print, as well as in digital platforms. And she's also the co-developer of a pharmaceutical grade anti-aging skincare that was featured on HSN. And so she's associated with many professional organizations and societies, and we're just happy to have her here to discuss acne and rosacea in skin of color. Welcome.
Thank you so much, Dr. Allen, and thank you to Renee Wall, James Albertson, and your entire team at Oklahoma University Health Science Center. It's been great working with you, and thank you to the audience for being here. This is a full day, and we're starting to wrap it up, so I hope I can send you home with some pearls on treating acne and rosacea, not as exciting as cosmetic procedures and some of the other things we've discussed today, but let's go home with some pearls and let's get started. So I'm not an expert at doing the,
Oh, wow.
let's see, at getting the presentation up.
You may share
Okay.
your
So
screen.
share my screen. Got it.
And then should be in your background on one of those thumbnails that pops up, your PowerPoint.
Oh, here we go.
Yes.
Almost there. Can you see my screen?
Perfect. Excellent.
Oh, great, perfect. So yes, I'm very honored to be at the Mark Allen Avery Skin of Color Symposium, and I'm going to present to you some information on acne and rosacea. So my talk is the management of acne and rosacea in skin of color, the challenges, special considerations, and therapeutic options. And as Dr. Allen says, I bring you greetings from New York. So these are my disclosures and mitigations. And I will be discussing one off-label therapy that I have gotten great results from. Patients love it. And so it's just one that I want to share with you. And so we'll do that today. These are the gaps that we're seeing in terms of skin of color and acne and rosacea. They are even wider for rosacea, but we'll talk about that as we go along. And these are the objectives: to recognize the unique characteristics of patients with skin of color and acne and rosacea, diagnostic pearls for diagnosing and managing acne and rosacea, special considerations that need to be made, and the development and management of treatment plans and best practices. So now, when we talk about acne and rosacea, both of those diagnoses are considered very common diagnosis overall. But when we look at the numbers of patients that we see specifically in skin of color in those pools, those numbers decrease dramatically, especially in rosacea. Now, the acne pool increases exponentially, with over 65 million teens and young adults in the US with acne, 2 billion worldwide, over 7 million visits per year for acne treatments, 2 to 5 million visits are for inflammatory lesions alone. Over $10 million is spent only on oral antibiotics, and over $100 million are spent from over-the-counter treatments for acne. When we look at the prevalence of acne and skin of color, about 22.2% are Hispanic or Latinx, 22.1% are Black, and 18.7% are Asian. So, and of course, there are other types of skin of colors that are in that group. So we have a pretty good representation of skin of color in the acne diagnosis. When we look at rosacea, we're looking at a different, lower group age range from 30s to 60s. In the acne, we're looking from 9 years of age to 60 years of age, or possibly older. And the rosacea pool is over 1.6 million visits per year for rosacea, affecting 16 million Americans. There is $165 million spent each year on treatment, and even $78 million lost on the productivity among patients and caregivers who are treating rosacea. In terms of skin of color of rosacea, here's where you see a vast difference in terms of the skin of color patients with this diagnosis. Only 3.9% are Hispanic or Latinx, 2.3% are Asian, and 2% are Black, and up to 10% only skin of color globally. Now let's focus a little bit on acne vulgaris and skin of color. The psychological and emotional impact of acne can be surprising, because we think of acne as something that's almost a rite of passage. And that's what I heard when I discussed it with a group of pediatricians. But Scholzberger and Zadens in the mid-1900s stated that there is no single disease which causes more psychic trauma, more maladjustment between patients and parents and children, and more general insecurity and feelings of inferiority, and greater sums of psychic suffering than does acne. People suffer from social withdrawal and poor body image, and it has been noted that Asian females report greater negative impact on self-perception and social functioning compared to all other racial groups. There's decreased self-esteem, even depression and suicidal ideation, frustration and anger, embarrassment, and certainly preoccupation with appearance. And this is found very often in darker skin types, in Black skin, Hispanic skin, that post-inflammatory hyperpigmentation really preoccupies their mind and is more bothersome sometimes than the acne itself. And these are some of the examples of that post-inflammatory hyperpigmentation that patients come in to say, "Doctor, I need you to get rid of this." Kellett and associates also looked at the psychological impact and felt that the effect of acne is greater than that of psoriasis and cancer, not to undermine the really deep psychological concerns about psoriasis and cancer, of course, but acne is up there in terms of the impact that it has on patients. So now we're going to go to the presentations of acne. Here you see the typical breast presentations on the left side of the screen: comedonal, inflammatory, cystic, and nodulocystic, which seems to be increased in the Hispanic population. The dyschromias, which can be post-inflammatory erythema or post-inflammatory hyperpigmentation and scarring. We see specifically keloidal scarring increased in Blacks and Asians, and other skin of color presentations are listed on the right side of the screen, and we'll talk about them one by one. Here you see patients in skin of color with pomade acne. This is commonly seen in skin of color in individuals with a genetic tendency towards coiled and curly hair. The location is mostly on the forehead and along the hairlines, which makes sense. And it is tied to the use of pomades to enhance beauty and to improve the manageability of hair in this group of patients. To treat this, we ask patients to substitute the thick, heavy pomades with non-comedogenic products such as silicone or water-based products for hair care. Here we see some of those thick, heavy pomades, oils, heavy creams with petrolatum, lanolin, and wax in them that we want patients to avoid or limit. Here are some examples of the silicone-based alternatives that patients can utilize in response or in replacement to the thicker and heavier pomades. Now we'll speak about comedonal acne, which we saw also in pomade acne, and it's commonly seen in acne where there is occlusion as the primary etiology. So this also occurs with sports helmets, with hats, or anything that causes occlusion to the skin. In this type of acne, most if not all of the lesions are comedones. There are few inflammatory lesions or not, and we'll talk about that in a moment. And there's several tan and brown macules that can be seen. The introduction of the inflammatory comedone is why I say maybe there are only few inflammatory lesions, because in comedonal acne in African American females specifically, you can see a large amount of inflammation. Dr. Halder at Howard University and his colleagues did a research study that looked at comedones in African American females, and biopsies were actually taken of these comedones. And what they found was that African American patients tended to have a significant inflammatory component in their comedones, which are traditionally considered non-inflammatory lesions. This intense inflammation from comedonal acne just in and of itself can lead to substantial dyschromia. So this requires more aggressive treatment than we realize, and treatment which should encompass anti-inflammatory agents very early in the course. Another type of acne is acne cosmetica. This is a type of acne that, in efforts to cover up the post-inflammatory hyperpigmentation, and you'll hear a lot about this in this presentation, that people hate with oil-containing and heavy, creamy, opaque foundations, can cause actually worsening of their pre-existing acne and worsening of those comedones. So what we recommend for acne cosmetica are water-based foundations or mineral makeup. Here we have acne excoriate, and in these patients, they have an overwhelming desire to pick or scratch lesions on the face, and sometimes just areas on the face where they don't even see lesions. There is a strong psychological connection associated with this type of acne, and this can occur in any patient population, any skin type, any ethnicity, and is related to stress, anxiety, obsessive compulsive tendencies, and negative emotions. It is very important in skin of color because of the sequelae that we can get from this type of excessive picking, which is that dreaded, again, post-inflammatory hyperpigmentation, hypertrophic scarring, and keloidal scarring, which can be long-term and very difficult to treat. Treatments for this acne excoriae includes the traditional medications that we do use to treat acne, but also psychological support is very necessary. Professional support can do a lot of good for these patients, but there is a stigma very often in different cultures about us accessing psychological support, and it's thought negatively on in order to get this support. So we have to sometimes do a very good job convincing these patients to gain psychological support. For those who don't want to do that, there are support groups, there are in-person support groups, and there are even internet-based support groups that give you even greater privacy, such as one called stoppicking.com. Now, here's an example of steroid acne, and I also label this as inflammatory acne because in steroid acne, you do see primarily inflammatory lesions, papules, pustules, nodules, and cysts. There is some post-inflammatory hyperpigmentation associated in steroid acne. And the interesting thing is most people who have steroid acne have it because they are looking for treatment for their post-inflammatory hyperpigmentation, those darn dark spots again, and they end up going to their local neighborhood bodegas or health and beauty stores in their neighborhoods for skin lightening products. And the skin lightening products that are often sold in these types of establishments are actually very potent topical corticosteroids. So it's not only found in patients who overuse legitimately prescribed steroids on the face or the body, but patients who don't even know they're using topical steroids because they think they are lightening products. Keloidal scars from acne can be very, very common, especially in Blacks and Asian patients, and these result obviously from inflammatory papules, nodules, and cysts, and are also usually associated with post-inflammatory hyperpigmentation. They can be subtle scars like you see in the first two pictures that we have here, but they can be also very extensive keloidal scars as you see on the backs and arms of the patient in the last picture. To treat these keloidal scars, we utilize triamcinolone acetonide, 2.5 to 5% to 5 milligrams per cc intralesionally. But for someone with very large keloidal scars like we see in the last picture, they may require higher concentrations of the triamcinolone acetonide, as well as phototherapeutic and other X-ray and photo treatments to those keloidal lesions. We try not to do surgery on the keloids because you know that healing for patients that are prone to keloids can be associated with even greater keloidal growths. Now, the dreaded post-inflammatory hyperpigmentation. This is one of the most common sequelae of inflammatory acne, and as we know now, of some comedonal acne, and it is often the initial presentation and the reason skin of color patients seek care. The treatment that we give to patients who seek care for acne or for post-inflammatory hyperpigmentation with acne, most times needs to include in the initial treatment regimen treatment for the post-inflammatory hyperpigmentation so that patients feel like you have heard them, that you hear that they are very bothered by this post-inflammatory hyperpigmentation as they are the acne, and they want something done about both. Treatments that can be helpful for that are the retinoids that we include in our treatment regimens for acne patients. Sunscreen use, I tell patients, is just as important when you're trying to cure post-inflammatory hyperpigmentation as the medications that we use for the acne and for the pigment. And azelaic acid is that special product that I wanted to tell you about. Although it is FDA approved for the treatment of acne and not FDA approved for the treatment of hyperpigmentation, I find it very, very effective along with retinoids in treating patients for both acne with mild to moderate acne and hyperpigmentation. So what I tell the patients is to use the azelaic acid. I also prescribe to them a 15-gram tube of a low-potency topical steroid, such as Desinide or 2.5% hydrocortisone. I have them mix a drop of each together, the azelaic acid and the low-potency steroid, and I have them to use that over the entire face for about 2 to 4 weeks. After that 2 to 4 weeks, I follow up with the patients and we discontinue the topical steroid at that time. And this is very helpful to have a successful treatment protocol because azelaic acid in and of itself, along with other acne medications such as retinoids, can be drying and irritating. And the 2 to 4 weeks of low potency topical steroids can help them kind of gradually grow into getting used to the retinoid and used to the azelaic acid so that at 2 to 4 weeks, they can stop the topical steroid and mix the azelaic acid with a facial moisturizer and follow the retinoids also with the facial moisturizer. And of course, in the mornings, they'll use sunscreens to be reapplied every 2 hours if they are still in the sun or going in and out of the sun and 2 hours have passed. Other treatments for post-inflammatory hyperpigmentation include the use of certain acids, such as glycolic acids, salicylic acids, lactic acids, mandelic acids, and kojic acids. Hydroquinone is considered the standard of treatment, but can be a little bit difficult to use, especially if you have numerous, very tiny, small dark spots on the face from your acne lesions. Arbutin, green tea, and vitamin C are cosmeceutical treatments that can also be used. We mentioned chemical peels. Microneedling can be used to break up the pigment, as well as lasers, particularly the 1064 Nd:YAG laser that was mentioned before, but this one is the non-ablative laser that can actually target that pigment and gradually get rid of it along with your topical treatments. Now let us take a moment and look at the pathophysiology of acne vulgaris. So although, again, we look at acne as a very common disease and don't put a lot of thought into what's happening with acne, it's a pretty complicated pathogenic process dealing with follicular hyperproliferation, androgen stimulation, increased sebum production. The cytokines chime in and call in the inflammation. So there's an inflammatory cascade, which includes Propionibacterium acnes, as we called it in the past, currently called Cutibacterium acnes. The neutrophils and mononuclear cells are called in, and a full inflammatory process takes place, which stimulates melanogenesis and other inflammatory mediators, and you end up with those dreaded post-inflammatory hyperpigmented lesions. And when there's a significant inflammatory response, you can end up with those hypertrophic scars and keloids. Here we see where the cytokines help to mediate that complex inflammatory cascade, and the cytokines act on our endothelial blood vessel cells to recruit other inflammatory cells such as neutrophils. Those neutrophils arrive early in this process to that site and recruit additional neutrophils, meaning more inflammation, and you can end up with a very inflammatory process, which means we do need to approach acne, especially in skin of color, even though it may not appear to be significant inflammatory. We need to do it early and we need to do it aggressively without causing irritation. There are ethnic differences in the physiology of acne vulgaris. We've already talked about comedones having been shown a significant inflammatory component. Papules and pustules have infiltrates that actually extend beyond the lesion. So we know that they're inflammatory, but these infiltrates extend beyond the acne lesions, and specific mediators that exacerbate the melanocyte response and result in cutaneous injury and further inflammation. These differences are what is associated with this potential sequelae of post-inflammatory hyperpigmentation and why we see it so commonly in patients with skin of color. So what do we do about that? When you see the acne, no matter at what phase it's in, treat it right away. The earliest clinical expression of acne can be a non-inflammatory comedone, but the comedones may have significant inflammation in skin of color. Our key goals are to minimize follicular occlusion, prevent proliferation of the Cutibacterium acnes, short-circuit the overall expression of inflammatory lesions by getting rid of those inflammatory cytokines and mediators, and to do it very early on. Here are many of the treatments that we use in the treatment of acne vulgare. There are antibiotics, anti-androgen treatments, there are retinoids, and there are other treatments such as benzoyl peroxide, azelaic acid I mentioned, dapsone, and combinations of treatments. And combination treatment can be very important in terms of patient compliance, because if you can get a patient to apply the medication once a day, you might get a lot more compliance than having them to have to put on something in the morning and in the evening. Here we see combination treatments with clindamycin and benzoyl peroxide, and we see that with medicines such as Onextin. We see combination treatments, a triple combination of clindamycin, benzoyl peroxide, and adapalene, which we see in Cabtrio, which is a new acne medication, tretinoin with benzoyl peroxide that we find in Twinio, and adapalene and benzoyl peroxide that has been around for quite a while in Epiduo and Epiduo Forte, and can be, like I said, very helpful for patients in terms of getting them to use the medicine just once a day and having a really good outcome because you are using combination treatments. Now, we looked at the classifications of the treatments, and what we want is the retinoids to normalize desquamation and focus on reducing the inflammatory response. The antibiotics work to reduce the microorganisms and the inflammatory response, as well as benzoyl peroxide, which reduces microorganisms. The isotretinoin affects the sebum, normalizes desquamation, inhibits the bacteria, and reduces the inflammatory response. The hormonal treatments reduce the sebum, and then laser and light treatments also help to reduce the sebum, normalize desquamation, inhibit the bacteria, and reduce the inflammatory response. But in order to provide these for the patients, we have to get them to come through the door. We have to get them to come see the healthcare professionals. And this is where we see lots of disparities in the management of acne and skin of color. In fact, Black, Hispanic, and Asian patients were less likely to see a dermatologist or a healthcare professional as compared to whites. Black patients receive overall fewer prescriptions for acne medications as compared to whites. Black patients, unfortunately, are more likely to be prescribed topical therapies and less likely to be prescribed oral medications, even when they have moderate to severe acne. And Hispanic patients had lower odds of receiving topical retinoids than non-Hispanic patients. So in managing our acne patients, we want to get a good history, and that we need when we're managing most conditions in dermatology. We want to find out the patient's perspective. We ask the patients, when you look at yourself in the mirror, what do you see? What are the first things you see on your face? Many patients say, I want to get rid of those dark marks. That's the main thing that I want to do. You have some that will say, I want to get rid of the acne bumps, but the dark marks seem to be the overwhelming response. You talk about family history and the patients that have suffered from acne in their families, treatment history, treatments that they may have used that they may have had some success with, or complications that they may have had from past treatments. You look at the location and extent of their lesions in their physical exam, as well as the lesion type to determine severity, and you develop an appropriate plan for the current severity and sequelae that they're dealing with, and discuss the prognosis, giving them realistic expectations of what to expect. They're not going to see clearance of those acne or dark spots in 1 week, and maybe not even in 2 weeks. I let them know that if they're very lucky, they may start to see a difference in 2 weeks, but it can take 4 to 8 weeks, or sometimes even longer, to even start to see a difference in their acne, and certainly in their post-inflammatory hyperpigmentation. Also, I add to this chemical peels, microdermabrasion, microneedling, which helps to break up the pigment packages, and lasers that we spoke about. And I want to take a second to talk about benzoyl peroxide, because if you looked at the combination treatments, every one of them contained benzoyl peroxides, and almost all over-the-counter benzoyl peroxide treatments for acne contain benzoyl peroxide. So there was a research study recently done by Valashore, which discovers that benzoyl peroxide treatment for acne containing products are unstable and form benzene, which is a known human carcinogen in patients that use benzoyl peroxide. So what do we do with this information? So we know that benzoyl peroxide now can degrade and form benzene, that benzene can be harmful and problematic and can be carcinogenic for patients. So what do we tell our patients when we talk about the benzoyl peroxide? Well, benzoyl peroxide has been a staple in our treatment of the acne patients, and it's very important in terms of bacterial resistance. In the study, the benzoyl peroxide was heated up to 50 degrees Celsius, which is about 122 degrees Fahrenheit, which is really not a real life situation. No one literally cooks their benzoyl peroxide. However, we must take this seriously while we gain more information and a better understanding of this process. What we have advised patients is that they are to avoid putting benzoyl peroxide containing products in their bathrooms, which get hot and steamy. They need to avoid radiators and other heat sources around their benzoyl peroxide products and avoid leaving them by accident in hot cars. Patients have also been advised possibly to refrigerate these products and don't keep them around too long, as we know now that the longer they're around, there is a degradation process which could lead to higher levels of benzene in these products. Out of the 66 products that were tested, 19 of these products were actually found to have small levels of benzene at baseline even before they were heated. So, I offer patients to use the benzoyl peroxide containing products, understanding these conditions, and to make sure they keep the products cool and away from heat. Or I give them the option of also being prescribed something without benzoyl peroxide. So treatments for acne, when we're managing it, should target the acne and the post-inflammatory hyperpigmentation in patients of color. We should treat it early and aggressively to help decrease potential PIH and scarring while minimizing irritation. We need to instruct the patients how to use retinoids to avoid what we call a retinoid dermatitis, which can be severe irritation and rawness of the skin from the retinoid. All acne products can really cause irritation and dryness. And with retinoids in particular, we sometimes start them out every other night or 3 times a week until their skin adjusts to the retinoid, and then they can increase it to every night as tolerated. Combination therapies are very important, and that can be combinations, as we see, of the different medications, as well as combinations of topical medications with oral medications, and combinations of topical and oral medications with chemical peels and lasers with devices. The end goal for us is clearance of the acne and the post-inflammatory hyperpigmentation. So let's move on to rosacea in skin of color. Rosacea in skin of color is underestimated, it's underreported, and this is due to a lack of awareness by both patients and physicians, and lack of recognition by even healthcare providers and physicians, and certainly lack of recognition by patients, and therefore it is underdiagnosed. Rosacea actually can even be misdiagnosed in white skin and fair skinned individuals. These misdiagnosed patients and delayed diagnosis of rosacea leads to increased morbidity, including disfigurement of the face, loss of vision acuity, and an overall decreased quality of life. So we saw the numbers before, the very low numbers of the percentage of skin of color patients in the US with rosacea. But if we group this by race and ethnicity, and if you see in this chart, we've included American Indians and Alaska Natives. We see that skin of color can be less than 5% of rosacea in the United States, while Caucasian skin is from 95.7% to 96.7% in the skin types 1 and types 2 population. When we break it down even further to Fitzpatrick skin type, and we group the most richly pigmented skin of color, skin types 5 and 6, we find that almost no patients in that group have been reported to have rosacea, and almost 100% of the patients in Fitzpatrick skin types 1 through 4 are the ones that are reported to have rosacea. But remember, that's because a lot of misdiagnoses are made and rosacea is not recognized, especially in those very, very richly pigmented patients of color. Looking at rosacea, the clinical presentation, we see 4 major classifications. These include metallotelangiectatic, excuse me, that's always a tongue twister for me, rosacea, papulopustular rosacea, phymatous rosacea, and ocular rosacea. Now, granulomatous rosacea is included amongst the subtypes. It is a variant that is seen most common in skin of color. So here we have erythematotelangiectatic, there we go, erythematotelangiectatic rosacea in both a type 1 to 2 skin patient in the first picture, and in the second picture you see a patient with skin of color, and you see the central erythema in both patient types, which is a primary diagnostic indicator of rosacea. But if you look at the patient with skin of color, you'll see that it's a more violaceous or brown look of the central erythema, and it almost blends in with the skin color. So it can be very difficult to perceive. There is flushing that is frequent and particularly prolonged. And so in patients of color, you may want to ask about a warm sensation because they may not recognize the flushing, but they may feel that warm sensation. And also, you want to ask about burning and stinging. You want to look for skin edema and a dry appearance amongst these patients. In this type of rosacea, telangiectasias can be a very helpful physical sighting to make the diagnosis of rosacea, but it can be very difficult to see in skin of color. So some of the diagnostic tools that we use are dioscopy, as you see in the first picture, where they're using a slide to press down on the vessels to see if they blanch and reappear when they release the pressure. A dermoscope can be used to evaluate for telangiectasias, and there are other visualization systems that can be utilized. Here in papulopustular rosacea, we see the major criteria of papules and pustules, and the difference in this and acne is that there are no comedones, and there is also an erythematous background in patients with papulopustular rosacea, along with the papules and pustules, where you don't necessarily see that in patients with acne. Again, these patients have the flushing that is frequent and typically prolonged. In patients of color, remember to ask them about that warm sensation, this burning and stinging, edema, and that dry appearance to the face. These are phymatous changes, and phymatous changes are basically a diagnostic giveaway. It's very hard to miss this. And these patients here, you see a patient that is skin type 2, and you see patients that are skin type 5 and 6 with the bulbous noses. They have enlarged pores in the affected area. They have thickening of the skin and overgrowth of the tissue with swelling and a waxy and rough texture like we see here. For these patients, treatment plans often will have to include antibiotics, and if there's no response with antibiotics, oral, then we need to consider oral isotretinoin, and surgical approaches can also be very helpful in skimming some of that thickened skin away, including laser treatments to close those vessels and to reshape the nose. But this is a diagnostic giveaway. When you see these spinatus changes, you know that you're dealing with rosacea. Now, there is one thing that has been associated with spinatus rosacea, and that is it is a sign of heavy alcohol use, and that actually is not the case. It is not necessarily associated with heavy alcohol use. Ocular rosacea, we see it here in the person of skin types 1 and 2, and we see it here in a patient with skin types 3 to 4. And again, it is a major manifestation of rosacea. It's a key screening tool because 50% of these patients have symptoms. Patients are often asked if they have a gritty feeling in their eyes, a foreign body sensation, itching or irritation in their eyes. They may have been feeling this and not knowing what was causing it, and it can turn out that it is associated with rosacea. Now, this is the granulomatous variant of rosacea, which is more common in patients with African ancestry. There is no persistent facial erythema with the granulomatous variant. The papules are monomorphous and they can be yellow, they can be brown, red, or skin color. They can be periorificial, so they can occur around the eyes, around the nose, around the mouth, or they can occur on the lateral face. There is prominent symmetry in these patients. Now, there is also a type um, of a granulomatous facial disease called facial Afro-Caribbean childhood eruption that looks very much like the patient in the first picture. And this usually is found again in African patients and patients of African ancestry, and commonly in prepubertal males. In this type of granulomatous variant, it can sometimes be mistaken with sarcoid and tuberculosis. Biopsy can be helpful for that, and certainly a quantiferon gold to rule out tuberculosis can also be helpful in making that diagnosis. There are mimickers, different disease processes in the skin that can look very much like rosacea. We talked about acne vulgaris, which does have comedones, can have a lot of post-inflammatory hyperpigmentation, as you know, but doesn't typically have the flushing or the telangiectasias. Systemic lupus erythematosus can have a central facial rash, which in lupus is called a malar rash, but this in lupus usually spares the nasolabial fold, and there are lack of papules and pustules. Biopsies can be helpful as well as serology. And seborrheic dermatitis, which is very common and can very commonly be associated with rosacea, but you typically will see more scaling and erythematous patches. You see it around the nasolabial folds, the hairlines, the auricular areas, and the eyebrows, and they may or may not have post-inflammatory hyperpigmentation associated with these lesions or hypopigmentation associated with it. Sarcoidosis can also be a mimicker of rosacea. Biopsies finding non-caseating granulomas can be helpful. And also radiographic evidence of multisystem involvement can help us to diagnose sarcoidosis or rule out sarcoidosis and diagnose rosacea. Contact dermatitis can have the central facial redness, but will have the lack of flushing and telangiectasias, lack of papules and pustules, and it's often the symmetrical erythema, which can be central or diffuse. Dermatomyositis, you find musculoskeletal findings associated with the central erythema, and this erythema often in all skin types can be dusky or violaceous. And last but not least, steroid dermatitis, which can affect anywhere on the face that the steroids were applied. So the management of rosacea also includes a good patient history, management of triggers, and talking to the patients about how they feel and how their rosacea affects them and their lifestyle. A physical exam is important to determine the type and severity of lesions that they have with their rosacea and a plan for their current severity and prognosis. And the end goal in rosacea is a clear face without symptoms. Here we see a list of triggers with sun exposure, emotional stress, and hot weather being the three most common triggers, but they are many triggers, and this is just a small list. There can be hundreds of triggers, and they're not the same triggers for everyone. So I encourage my patients to look up several lists of triggers to find out if they can relate any of these triggers with their breakouts of papules and flushing and erythema and warm sensations to diagnose rosacea. And these are some of the topicals that we use, some oral medications that we use, and skincare is vitally important. You want to make sure these patients have sun protection, mild cleansers, emollients that are ceramide based that can help repair the barrier and that contain niacinamide, silicone-based emollients, and camouflages as necessary to camouflage some of their erythema. And we want to obtain a family history and their ancestry, rule out the mimickers, evaluate the triggers, make patients aware of these triggers, and the treatment should target, as we said, gentle skin care, barrier repair, regular sunblock use and sun avoidance, trigger management, and significant clearance or reduction of their inflammatory lesions, telangiectasias, their vasomotor instability, as well as the flushing and erythema. So in conclusion, there are many disease processes that are unique in skin of color, including acne and rosacea. They can be either uncommon in white skin or uncommon in skin of color or lack of occurrence in white skin or uncommon appearance in skin of color. There are unique etiologies such as pomades and cosmetic cover-ups in skin of color, unique presentations and unique features. There are brownish, violaceous appearance of erythema, which can be a real hindrance in terms of diagnosing rosacea in skin of color. And rosacea can also be granulomatous, where you really don't have the erythema and the flushing that you have in the typical rosacea. Clinicians, scientists, and professionals in the health and beauty industries need to be able to recognize these unique entities and their associated features. Cultural competence is very important in being aware of cultural influences and practices that can contribute to or hinder the success of the treatment. We've achieved great strides in making these diagnoses and recognizing these features. Deficits still remain, and more evidence-based research and scientific investigations and collaborations, such as this Mark Allen Everett Symposium, are the keys to greater understanding of these types of disease processes. Thank you very much. And now we'll take questions.
Thank you so much, Dr. Bolden. The first question was, can you comment on your results with clascoterone and how do you use this in your patients?
Clascoterone, if you remember, is listed under the anti-androgen or hormonal treatments for acne, and it is to be used twice a day. I tend to focus it for patients who complain that they typically break out around the time of their menses or the 2 weeks before, which might be ovulation, or the 2 weeks after their menses. So I focus it on those patients. I utilize it a lot in male patients. And I do include a retinoid, which can be used every other night, alternating with the medication at night and using it solely in the morning for those patients who tend to have a more hormonal history of their acne.
Next question was, what type of facial cleansers and moisturizers do you recommend?
Both for acne and rosacea patients, because treatment of acne can cause dryness and irritation, and patients with rosacea already have very sensitive skin. I do recognize very gentle cleansers, non-fragrance, ceramide-based cleansers that may contain niacinamide, um, and cleansers that focus on barrier repair. So ceramides are a great thing to look for in these cleansers, and you can find them in cleansers like CeraVe, and cleansers like Cetaphil, and cleansers by Eucerin, by Aveeno. There are many different ones that are available on the market.
Do you have specific recommendations for patients with ocular rosacea, either over the counter and or prescription treatments? And at what point do you refer to ophthalmology?
Very good question. Patients with ocular rosacea, especially with skin of color, are so helpful in terms of making that diagnosis of rosacea. And they can say, yes, I do get that gritty feeling. I do get that irritation, that foreign object sensation in my eyes. Oral antibiotics that we use to treat rosacea, such as doxycycline or minocycline, can be very helpful in terms of treating the ocular symptoms of rosacea. If I am giving the patients oral antibiotics along with topical treatment, and we don't get some relief from those symptoms, from those ocular symptoms, I then tend to refer to an ophthalmologist.
And the last question is, would changing the patient's diet to plant-based help with these skin conditions?
So that is a very good question, and there really hasn't been any strong evidence-based research that states that a plant-based diet will help with the symptoms of rosacea. Um, we do know that we want to avoid as many chemicals as possible. And in terms of skincare and treating rosacea, we want to use more um, botanical, I would say, treatments. So there is a chance that plant-based diet may be helpful, but I think we just don't have enough information at this time.
Thank you. We had one more question come up in the chat. What dosing do you use for oral doxycycline for rosacea, and how long do you keep them on it if stable but flaring without it?
The dosing for oral doxycycline, um, most often I use 100 milligrams twice a day. But for patients that are very small or very thin, and so I do look at their weight, I may only start them out at 50 twice a day or 75 twice a day. And I also, if it's available to the patient, like to use Oracea for patients, which is the 40 milligrams once a day.
All right, well, that seems to conclude the questions at this time. I want to say thank you so much, for just agreeing to be here today and presenting such a practical approach to acne and rosacea and skin of color. It is just a pleasure to have you. And those who still have questions later on, I'm sure she can put maybe in the chat her email for further discussion. But I want to say thank you once again, and we hope to have you in the future.
I will certainly put my email in the chat. Thank you very much.
Thank you. Thank you so much.